Friends, this is a mature non-intumescent cataract. I have taken up this case for surgery. Let us observe the surgical steps. The main incision has been made, that is a 2.8 millimeter incision. This is a side port on the left side of the main incision, and this is air. I'm going to stain the anterior capsule with trypan blue dye. I didn't suspect any problem in this case, and I missed something that will be revealed very soon. So the trypan blue dye has been applied, the capsule has stained nicely, and now I'm going to use viscoelastic substance. This is HPMC, hydroxypropyl methyl cellulose. Now one more side port is to be made. This is one more side port on the right side of the main incision, and now I'm going to do capsulorhexis. This is my technique. I incise the capsule with a bent 26 gauge needle. Then I hold this capsular flap with ureter forceps. I tent the anterior lip of the main incision, and the viscoelastic substance doesn't come out, and I can complete the rhexis at on go. That's it. The rhexis has been done nicely. Now there is something white, dense white at the center, but I missed that. Now I can see, but in a hurry I missed that this could be a posterior polar cataract, and I did hydrodissection as a normal case. And now I am going to do phacoemulsification in this case. This is Oatley Cataracts 3 phaco machine. I have started in phaco 2 mode. I usually do direct chop. The phaco tip is buried in the substance of the nucleus, and I chop the nucleus. Yes, nicely it has chopped. And now here, yes, I can see the PC rent, but in a hurry I missed that. And now a small nuclear fragment has gone into the vitreous cavity. So I stop now. I ask my assistant to give me viscoelastic substance. I hold the needle half, and she injects viscoelastic substance. I stop irrigation, and then I come out. And now the almost 3/4 of the nucleus is there. What to do now? A lot of lens matter is there, and there is a big rent. So I've taken a Sinski hook. I have prolapsed the nucleus in the anterior chamber. Now I can see the dropped nuclear fragment at 2:45 o'clock. That white reflex, fuzzy with fuzzy margin. Now this is a hydrophilic acrylic intraocular lens. I should have used a hydrophobic multipiece intraocular lens, but this patient is from an eye camp selected by one of our optometrists, and because of economic reasons I have asked for this lens, a hydrophilic acrylic intraocular lens. I'm going to use that lens as an scaffold and complete phacoemulsification. And now this is the dropped fragment. I brought it. This didn't sink because the vitreous is in gel form. Now I'm using a capsulorhexis forceps to hold it and bring it anteriorly. Here it is. I can hold the nucleus and I could bring it anteriorly, but it is entangled to vitreous strands. So I have taken a Vanna scissor and I'm going to cut the vitreous strands which is below the fragment, nuclear fragment, to make it free from vitreous strands. And now it is free and I could push it towards 3 o'clock over the anterior capsular rim. And now I'm going to implant the intraocular lens over the iris, that is in the anterior chamber. I am enlarging the incision a little bit, say by 0.2 millimeter, so that I can deliver the lens easily in the anterior chamber. Here it is. The lens is being placed over the iris. The leading haptic has gone over the iris. Now the trailing haptic is also placed over the iris. So the haptics are at on o'clock and 7 o'clock positions. And now I'm going to do some vitrectomy before and this must be done. You must free the nucleus from vitreous strands. And this is a very important step. And this small nuclear fragment has come out through the enlarged main incision. Now I am over the anterior capsule and I am cutting whatever vitreous strands are there underneath this nuclear mass. 3/4 of the nuclear mass is there. And now I'm going to inject viscoelastic substance between cornea and the nucleus for protection of corneal endothelium. And now is the time to enter into the eye again with the phaco handpiece. Now here it is. I did something wrong again. I'm here and suddenly the iris comes to the port. So now I am here. I've chopped this nuclear mass and I'm emulsifying it in the anterior chamber. Since this is a very soft cataract and for a very minimum time of about less than 1 minute I have used ultrasonic energy, I expect that the cornea will be clear tomorrow. Let us see. Now I am trimming the iris that got caught in the phaco tip. Now I am going behind the IOL and doing vitrectomy. Lot of viscoelastic substance and lot of lens matter is there here that is being cleaned by vitrectomy. and it's looking clean now. When I caught the iris, at that time the trailing haptic has gone into the sulcus. If it didn't go into the sulcus, it would have sunk into the vitreous cavity. So it must be in the sulcus. Now I am going behind the IOL and removing the lens matter. That's it. Here are some strands, so I have to go again with the cutter and trim these vitreous strands. Now I am going through the side port and removing the cortical matter from 9 o'clock. Now I am removing the cortical matter from 11 o'clock. Here I stop. I want to use the cutter again to trim this later on. It's looking good now. Here it is. I'm going again with the cutter and trimming the vitreous strands that I saw at 1:30 o'clock. That's it. Great. It's looking nice. Now I'm placing the haptic which is there superiorly in the sulcus. And I checked whether the other haptic is also in the sulcus or not, and I found that that is also in the sulcus. Now I inject some air, and this is moxifloxacin, and I inject some. Now I hydrate the side ports. Now after hydrating the side ports, I asked for pilocarpine. The pilocarpine is getting ready, and this is the pilocarpine. I didn't use triamcinolone acetate. This pilocarpine is a test that if the pupil constricts and if there is no vitreous strands, the pupil will be round. If some vitreous strands are there, the pupil will be picked. Though it is always confirmatory and probably better to use triamcinolone acetate, but in this case I am very sure that there is no vitreous strands in the anterior chamber. So the case is over. The antechamber has been formed and it's looking nice now. Hope this video will help you in developing your surgical skills. Thank you very much for your attention.